So good morning, everyone, and welcome to today's seminar entitled Our Understanding of SARS-CoV-2 Immunity, How Did It Evolve and Where Do We Stand Now? We are happy to have Dr. Hiam Chemaitelly, an assistant professor at Weill Cornell Medicine, Qatar, as our speaker. Dr. Chemaitelly's presentation will delve into the crucial aspects of immune protection against SARS-CoV-2, encompassing both natural infection and vaccination. It will encompass topics such as the dynamics of protection waning, the impact of variants and subvariants on immune response, viral evolution, and the intriguing concepts of immune imprinting. She will shed light also on the pivotal role that advanced digital health platforms play in advancing epidemiological research in the current era. As a brief overview of Dr. Chemaitelly's illustrious career includes her primary research focus on infectious diseases, with a particular emphasis on COVID-19, HIV, sexually transmitted infections, and viral hepatitis. Her scholarly contributions comprising over 120 research studies published in esteemed journals such as New England Journal of Medicine, JAMA, Nature Medicine, and Lancet. All of these have been instrumental in shaping public health policies. Her work has garnered international recognition, receiving widespread coverage in the media also. So I think today's seminar will provide us with valuable insights, and it will contribute to our collective understanding of SARS-CoV-2 immunity. And with that, and without further ado, I'll let Dr. Hiam Chemaitelly go more in details of this talk and to guide us through the enlightening seminar. So thank you for accepting our invitation, and the floor is all yours, Dr. Chemaitelly.
Thank you very much, Sam, for the kind introduction. Good afternoon, everyone. It really gives me great pleasure to be speaking at FHS Talk Series, being an alumnus of FHS. Today, I will present to you our journey in understanding immunity against COVID-19 and how we leverage the use of routine data as well as innovative epidemiological study designs to better understand the immunity against this new infection. Okay, I don't know what happened. Okay. This research has been done in Qatar, and as many of you know, Qatar is a small country in the Gulf. It has about 2.8 million people, the vast majority of which are expatriates from over 150 countries. Just like other countries, we have multiple epidemic waves, starting with the ancestral virus, the alpha wave, the beta wave. We had also a massive Omicron BA1 and BA2 wave, multiple other waves with Omicron subvariants. And right now we are actually going through an Omicron GN1 wave. Now we were lucky that when COVID-19 hit us, Qatar had already modernized its healthcare system, and it had in place an advanced digital health platform, which is the Cerner system. This platform tracks all public health encounters with the public healthcare sector, and this facilitated a lot the conduct of research. Now, since even before COVID-19 reached Qatar, when it started spreading throughout the countries, we worked very closely with the government on developing national federated databases for COVID-19 and on structuring the databases in a way that is amenable for research. These databases basically tracked all testing, hospitalizations, and mortalities, as well as infection severities in the country. And later on, we added vaccinations to it. And this was very important because we were on a mandate to support the COVID-19 national response. So this effort actually did not start immediately with research. our first mandate was to support directly the national response by using mathematical modeling, estimating the healthcare needs, estimating the need for acute care beds, for intensive care unit beds, for quarantine facilities. And that's why we really needed good tracking of all infections and infection transmissions happening in the country. However, with time, we really needed to understand better the epidemiology of this new infection to be able to guide better the response, because there were concerns about whether people who were infected were at risk of getting reinfected. There were questions such as, are we going ever to reach herd immunity? Are the vaccines that we are using effective, especially with the emerging variants? We were not sure whether these vaccines will work against these new variants. We also needed to estimate the infectiousness of the different variants. There were concerns that a specific variant is going, for example, to cause too much severity that we are going to reach the healthcare threshold with this variant. So all of these questions really induced or triggered a very interesting line of research. And we used different study designs. We used the conventional epidemiological designs, but also we used other designs that proved to be very effective in providing a timely response. And I'm going to present these designs today during my presentation. These include the test negative case control design and the target trial design. This research effort was a success story. So far, it generated over 15 major frontline COVID-19 discovery. And by frontline discovery, I mean that we were the first in the world to unveil specific aspects of COVID-19 epidemiology. So far, we've published nearly 100 papers, 13 of which were in the New England Journal of Medicine. And this is really an exceptional achievement for our region, because before these publications, there was only one publication ever from our region published in the New England Journal of Medicine. We also published in other top journals. And the type of evidence that we generated was very timely, that it did not only inform guidelines within Qatar, but also it informed guidelines at the WHO. And these were presented numerous times at high-level meetings, such as by Dr. Fauci in his White House press briefing and in US Senate testimony. And they were covered widely in international press and media. So I will start by sharing with you select findings on our studies on natural immunity. So since the beginning of the pandemic, we were very interested in getting to know whether people who got infected developed protection and to what extent this protection was durable. So we conducted several studies, and here I'm showing you a cohort study that summarizes these previous studies with a longer time of follow-up. And it appeared that before Omicron, there was a strong protection for natural infection against acquiring a reinfection. So individuals who actually got infected were 86% less likely to get reinfected than individuals who were infection naive. However, even from that moment, from very early on, we started seeing evidence that actually this natural immunity wanes over time and it's not going to be long-lasting. So we saw that the level of protection goes down from about 90% to about 70% a year and a half after the infection. So we knew then that unlike measles, for example, where the infection generates a long life immunity, SARS-CoV-2 actually doesn't generate such kind of immunity, and maybe more similar to influenza, where you are more likely to have repeated infections. And we were interested in knowing how long will this protection last. So we used mathematical modeling to predict durability, and it appeared that the infection will last for about 3 years. So we knew from very early on that herd immunity cannot be reached and that we will always have reinfections within the population. However, we looked at the severity of reinfections and compared them to the severity of primary infection. And this was the first study of its kind at the time. And we found that reinfections were way less severe than primary infections. In fact, they were 90% less severe than primary infection. So this was good news because it suggested that at endemicity, SARS-CoV-2 will adopt a benign pattern of infection, just like other seasonal common cold coronaviruses. And this is exactly what we are experiencing right now. We are having repeated waves of infection. However, these repeated waves have very mild severity. Now, we kept updating this study, and even during Omicron times, the evidence was consistent that actually reinfections are way less severe than primary infections. So this estimate, so we estimated that reinfections, even during Omicron, were 97% less likely to be severe and to lead to hospitalizations compared to primary infections. So this was very good news. We also looked at severity throughout the pandemic. And during the pre-Omicron, we estimated the incidence rate of severe, critical, or fatal COVID-19 to be 2 per 1,000 person years. And this was not surprising because many people were getting infected for the first time. During the first Omicron wave, the incidence rate actually increased to 3.7. But this is not because Omicron was more severe. It is simply because this wave was so massive, Omicron was so immune evasive, that people who were not infected previously got infected during this wave. But after this first Omicron wave, the incidence rate for severe, critical, or fatal COVID-19 fell dramatically by more than 90%. So it was only 0.1 after this first Omicron wave. And this is because now we are mainly seeing reinfections. And reinfections, as I mentioned earlier, are much less severe than primary infections. Now, while we were doing these studies, we encountered a problem, is that many times we really needed a rapid assessment of the protection of natural immunity against reinfection. Specifically when variants started emerging. Usually this kind of studies, we typically use cohort studies to examine the protection of prior infection against reinfection. However, the main issue is that by the time we accumulate enough follow-up time, a new variant would have emerged. So we needed something more efficient. We needed another study design that is more efficient and that can be easily applied to routine testing data. And here is where we came across the test negative case control study design. This is a study design that is well established for examining vaccine effectiveness against influenza, but it has never been used to examine the protection of prior infection against reinfection. And the main reason for that is that unlike vaccination, infections are not very well tracked usually in the population. So we wanted to investigate whether we could actually apply this design and get a valid and robust estimate for the protection of natural infection. So we used mathematical modeling and we simulated the epidemic in the population. Then we virtually applied this study design. We conducted a study where we estimated the effectiveness of prior infection against reinfection. And the results were very promising because the estimate generated by the model using the test negative design was very close to the true estimate in the population. However, we still had concerns overusing this study design, and we were mainly concerned about the misclassification of prior infection and how would this affect our estimate of natural infection protection. So we tested this also using mathematical modeling, and it turned out that the impact is actually very minimal because of the type of the statistical metric that we are using, which is the odds ratio. We also investigated how misclassification of latent infection could affect our results of current active infection. Another important point was also whether the scale-up of vaccination in the population could affect our estimate by being unable to distinguish between the protection from natural infection or from vaccination. However, all of these sources of bias turned out to have very limited impact on our estimates of protection using mathematical modeling. So now we move to another validation state, which is using empirical evidence. So before, we have already conducted studies, cohort studies, where we estimated the protection of natural infection against each of the alpha variant and beta variant. So we repeated these studies, but this time using the test negative case control design to see whether we are going to get estimates that are close or reasonable. And the estimates actually generated were even better than expected. They were very close to the estimates provided by the cohort study design. And this was very reassuring for us that now we have a new design that we can apply to estimate the protection from natural immunity. And as we were finishing the study, Omicron hit us. And it was the perfect application to apply this design to estimate the protection of natural infection against Omicron. And it turned out that Omicron was way more immune evasive than previous variants. So while the natural immunity provided earlier a protection of 90% against alpha, 85% against beta, over 90% against delta, it was only 56% against Omicron. And with the use of this design, we were actually the first to provide this estimate worldwide. So how immune evasion worked? Actually, it worked in two ways. First, Omicron reduced the overall level of protection by 40%. So we were no longer seeing a protection of 90%. The protection was reduced to about 50%. And more importantly, Omicron accelerated the waning of protection. So before Omicron, the natural infection protection would last for at least 3 years. Now with Omicron, the protection would last for only about 1 year. Now I will move to present to you some of the findings on studies that we conducted related to vaccine immunity. Vaccination in Qatar started in 2021. We mainly used the Pfizer and the Moderna vaccines. These are vaccines that were developed based on the Wuhan ancestral virus. And as we were scaling up vaccination, a new variant emerged, which was Alpha. So there were concerns on whether these vaccines would be effective against Alpha. So we estimated the protection against Alpha, and it turned out that it was at 90% for Pfizer 14 days after the second dose, and it was 100% for Moderna. Immediately after the Alpha variant, we had the Beta variant in Qatar, and Beta in Qatar generated a large wave. It was actually the most immune evasive before Omicron, and it generated lots of hospitalizations. So there were concerns actually on whether these vaccines were working against Beta. So we estimated the protection, and it turned out that indeed the protection was reduced, but it was still overall good at 75%. And for Moderna, it was strong at 90%. So this was reassuring. So we were very optimistic that with the vaccines, we will be able to get out of the pandemic soon and return to normalcy. However, this optimism faded away because soon after, we started seeing waning of vaccine immunity. So while it was a 75% immediately after vaccination, it fell to below 50% within 6 months. And we saw a similar pattern also for Moderna. However, the good news is that we really did not see a major waning in protection against hospitalization. So this was kind of reassuring, is that although we are likely to have more breakthrough infections, these infections may not necessarily lead to higher hospitalizations. However, there were more bad news coming with Omicron. Because what happened with Omicron is that the vaccine protection fell from about 75% to be at best 50% after vaccination. And the protection essentially was gone within 6 months. Now, we were lucky that we were having booster vaccination around the time when we had the Omicron wave. So booster vaccination restored the protection to the 50% level, but then again, we started seeing waning month by month after the vaccination. This being said, booster vaccines really helped us manage the Omicron wave because individuals who actually received the booster dose were 50% less likely to get an infection compared to those who only received 2 doses. And more importantly, they were 75% less likely to get hospitalized or to die from COVID-19. And this was really very, very useful because we had, with the booster, we had a massive Omicron wave. So if it wasn't for the booster, we would have had an even worse wave. So as we were studying vaccine immunity, there were interesting questions being raised. So we consistently were seeing that the protection from Moderna was stronger than Pfizer. And we wanted to compare Pfizer and Moderna head to head to see if this truly holds. And this is typically examined using an RCT. However, RCTs are very complex. They are very costly. So we thought of another design that we could apply to routine data to get similar results. So we applied the target trial design. And this design is very powerful. What is it essentially? It's an observational study design. It's like conducting the RCT, but retrospectively. And this design became possible with the use of electronic health records. So what we did is that we compared, so in the population already we had a lot of people who received 2 doses of Moderna and 2 doses of Pfizer. So we looked retrospectively and we found out that incidence for people who received Moderna was indeed 30% lower than incidence among people who received Pfizer. And this was due to the antigen dose. So Moderna had 3-fold higher antigen dose than Pfizer, and therefore the protection was also higher. So I just want to take a moment to talk about this design. One of the advantages of using the target trial design is that naturally, by using routine data, this design benefits from having very large sample size, unless other observation studies like, for example, RCT, where we have to recruit patients. And whenever we have larger sample size, we have higher precision in the estimates. And the studies also become more powered to look for rare outcomes. For example, we were able to look for associations with severe disease, whereas the actual RCTs for Moderna and Pfizer were not powered to look for these rare outcomes or to look for associations with adverse events. So this is one of the benefits of the target trial design. Also, using this design, it is very possible to investigate and conduct studies that otherwise would not have been feasible, as I'm going to show you in a minute. So there were questions being raised on whether people who actually got the infection naturally were more protected than people who got the vaccination. And this is a research question that is very difficult to answer using an RCT because for ethical reasons, we cannot go about and infect people and then compare them to vaccinated people. But it is possible to answer this question using the target trial design. Also, the design has very minimal cost compared to an RCT where the median cost is about $12 million. And it is far less complex logistically, and it doesn't require a lot of regulatory processes and IRBs and so on. Now, it has disadvantage because we are not strictly using randomization, but we can actually go around that using thorough matching and testing for bias testing for null effects. This is another application of the target trial design where we looked at comparing the protection from natural immunity to that of vaccine immunity. And it turned out that indeed, natural immunity provides better protection against a second infection, actually 50% more protection than vaccination. And it also provides 75% more protection against severe COVID-19. And the reason for that is biological, because vaccination is administered through an injection, and therefore it stimulates systemic immunity, whereas the natural infection induces a lot. It starts in the upper respiratory tract, and therefore it induces a lot of mucosal immunity. And the mucosal immunity tended to be better at protecting us against acquiring a new infection. This is why actually right now there are nasal vaccines against COVID-19 in development, hoping that the level of protection will be boosted and will mimic the natural infection protection. So as we were publishing the results of this study about natural infection being better than vaccination, there were a lot of questions about whether actually it is worth vaccinating individuals who already acquired the infection. So we looked into hybrid immunity, and this study was conducted during Omicron. And then we found out that a prior infection reduces the risk of infection with Omicron by 50%. For people who had the primary series or 2 doses, their protection was very low because these people received the vaccine several months earlier, if not a year earlier. And by that time, vaccine immunity waned. The protection of people who had 2 doses and a previous infection was actually comparable to previous infection because the 2 doses were really not adding much. People who recently received the booster actually had better protection than people who had previous infection. But the best protection was for people who actually had the natural infection and received the booster. Here, the protection for these people was 80%. So they were 80% less likely to get a new infection. And this affirmed the necessity of providing boosters even to people who had a prior infection, especially if these people had comorbidities or were of older age. We also had the pediatric vaccine in Qatar. Pediatric vaccination started in 2022, and it started with the 10 microgram Pfizer vaccine. The 10 microgram Pfizer vaccine is actually 1/3 of the dose provided for adults. And the results for this vaccine was very disappointing. The protection was only at 25%, and the immunity disappeared within 3 months. And we believe that what really contributed to this very modest protection are 2 things. First, the antigen dose is very low to generate enough antibodies to counter a new infection. And the vaccine at the time also was based on the Wuhan ancestral virus, and it was no match to the Omicron virus that was circulating. And just to highlight the effect of the antigen dose on acquiring a new infection, this is a study that we conducted, which compared adolescents who were 12 years old, who received the 30 microgram Pfizer vaccine, to adolescents who were 11 years old, who received the 10 microgram Pfizer vaccine. So the threefold higher antigen dose generated about 25% more protection. So the adolescents who received the 30 microgram Pfizer vaccine were 25% more protected against Omicron than those who received the 10 microgram vaccine. So this really emphasizes the importance of the antigen dose as an important factor in vaccinations. Now, as we were examining vaccine effectiveness, we came through a very interesting concept, which is immune imprinting or original antigenic sin. This is not a new concept. This is something that has been already observed for influenza and dengue, and we observed it also for COVID-19. I'm not going to go into details into this. I'm just going to provide a very high level overview of it because it's very complicated. But just to highlight what is immune imprinting, it's a phenomenon in which a specific sequence of immunological events can either enhance or compromise a person's future immune response against a new infection. So the key concept is that sometimes a specific sequence of immunological events can actually trap the immune system and make it unable to mount an effective response. And we observed this in a line of research studies, and I'm going here to show you one of these studies. So in the short term, the boosters worked very well at protecting individuals against infection, and as I showed you earlier, the protection immediately after vaccination was at 60%. The boosters also worked very well against severe disease with very high protection. However, after the waning of the antibodies and in the long term, we saw a negative impact. That is, individuals who received the 3 doses were not able to mount an effective response against a new infection compared to those who received only the 2 doses. And it seems that this effect that we observed only in the long term, not in the short term, arises from the mismatch between the immune memory, which is based on the Wuhan type, because we kept vaccinating people with the Wuhan vaccine. So as if we train the immune memory to always expect a Wuhan immune challenge. However, the actual challenge was very different. It was an Omicron, and it was a BA4, BA5. So this mismatch led individuals who received the booster dose to have lower effectiveness in the long term after the antibodies wane. So in the short term, the antibodies are protecting us against acquiring a new infection. But in the long term, the immune memory was not adequately trained to expect to counter the kind of immune evasive variants that were in circulation. And this is why right now there is a growing consensus that actually we should no longer use the Wuhan type vaccines, because what we need are more vaccines that match the circulating variants. And this is an example where also immune imprinting got manifested. So we had the bivalent vaccine in Qatar. This was the Moderna vaccine, and this vaccine combines the ancestral virus and Omicron BA1 strains. And the effectiveness of this vaccine was also very modest and disappointing. It had only 25% protection. And the main issue is that we were using in this vaccine the ancestral virus, which was no longer in circulation for a long time. So this vaccine actually was being scaled up at a time where we had BA4, BA5, and even BA2.75. So it was no match to the circulating variants. So now the trend is to move towards having monovalent vaccines, no longer bivalent vaccines, and vaccines that are the closest possible to the circulating variants. Right now, we are providing the XBB1 vaccine in Qatar, which so far, from global evidence, has high protection against the currently circulating GN1 variant. We haven't had the chance to study it yet here, but it appears to be working. This also so overall also this research on vaccine immunity suggests as well that we need to keep providing boosters for people who are at risk, basically the old and people with comorbidities, because similar to influenza, these people will be at higher risk of acquiring the infection, and we really need to keep boosting their antibodies to have at least a short-term protection. And now there are many developments into having a vaccine that actually combines both COVID-19 and influenza together. So in conclusion, COVID-19 immunity turned out to be much more complex than we were expecting. And there are really rich dynamics that still need to be understood, especially in relation to immune imprinting. Our experience suggests that we have a great opportunity to advance our understanding not only of COVID-19 epidemiology, but also of the epidemiology of other respiratory infections using the electronic medical records, and by applying and venturing into different study designs that are not commonly used. Also, there is a need for further development of epidemiological methods so that we can generate evidence in a timely manner, because really we could not afford to wait for a long time to answer specific research questions and attend to a public health, when attending to a public health emergency especially. And this can be done using the electronic medical records, and we can generate epidemiological inferences nicely and easily. And last but not least, I want to acknowledge the great strategic collaboration that allowed this research to be conducted, specifically with the Ministry of Public Health in Qatar and Hamad Medical Corporation, as well as other academic and non-academic institutions within Qatar. And thank you very much for attending.
Thank you, Dr. Hiam, for this very interesting talk. Now the floor is open for questions. If you have any question, please raise your hand, and or if you'd like, write your question in the chat box and I will ask it on your behalf. Dr. Milhim? Yes.
Thank you, Dr. Chemaitelly, for this wealth of published data and this important data that you've presented today. I came in late, so you probably have mentioned that, but I would like to know from your own expert opinion, as you know, epidemiologist of infectious disease and also a modeler, that in setting like many of the Arab world, where, I mean, we don't have sufficient information neither on key variables nor on confounders, what would be the best design that you would recommend in order to make such inferences that would really support and guide research and policies? And I totally agree with you that immune imprinting is really complicated because, and we drew inferences to it from HIV first and then influenza. And with the amount of data that is coming up about T-cell immune responses and the memory that is created and the length of it in relation to B cells against COVID, this is going to change also our understanding of how fast do we need to change and modify the components of COVID-19 vaccine, which has been done, as you already know. Because currently we do have now the monovalent vaccine. Is this available now in Qatar?
Yes, I just took the XBB, I think 2 weeks ago.
Perfect. Thank you.
Yeah. Thank you. Thank you, Dr. Nada, for your questions. Well, first, in relation to the data availability in the different countries, I mean, I agree the data capture may not be as complete as we would wish for and may not be as centralized. But all of the countries, they have to a great extent a functioning healthcare sector, with the hospitals having excellent records, with insurance companies having excellent records. And we never really delved into benefiting from these sources of data. So these data are routinely collected. I think insurance companies, they have great amount of data, you know, hospitals, they have great amount of data. So even if it is, if the data capture is not perfect, but I believe that it's still, we can still leverage from this if it was, if it had like people from the academic sector on board to structure these databases in a way amenable for research. Because of course, data, and many times they get collected, they are not properly amenable for research. But I think there is an opportunity to mainstream this data, which is even in countries that don't have an advanced digital health information platform. And for example, the test negative design, it really can be applied almost in any setting, even like at the level of one hospital, because when we are using, for example, metrics like the odds ratio, and this is like our the finding of our study, because we don't have differential misclassification, so actually the bias cancels out from the numerator and the denominator. So I really believe that if we have a little bit, if we can have a little bit more vision and more collaboration between the academic sector and the healthcare sector, that we can really achieve a lot, especially in the context of our region. And regarding immune imprinting, yes, I agree. It's a very subtle and complicated topic. I'm still myself struggling to find my way in it and to understand all the intricacies. But it's quite very interesting what we learn about all of these new infections.
Thank you very much.
Any other questions? Yes, Jad Khalife.
Hello. Yeah, sorry. It seems I'm on the wrong video camera. Thank you very much. Thank you very much for that interesting talk. And it's great to see this research coming out from our region. I think it's great also that you brought up several important points regarding the limitations of relying only on vaccination, I think, and the importance of boosting as well, and that is also very important. I'll just share a comment broadly, because I try to engage people on COVID, and I'm right now in Denmark. And the wave that we just had now in terms of deaths in Denmark was worse than last year. And you see that in some other countries as well, not all of them. It depends, of course, the monitoring, the surveillance systems and the testing varies so much across countries. But we're also seeing research regarding, of course, long COVID, There are now many publications on this, and we know that it has cumulative risk with every additional infection. And other publications more on the pathological changes that are happening, for example, due to infection having changes in the genome or in the genes in terms of the mitochondria, for one thing, which might explain fatigue or some types of long COVID, as well as other changes. There are so many papers, of course, coming out, but it seems like, to zoom out, it seems that there should be greater initiatives on prevention, on earlier lines, vaccination being one, but also ensuring that there is clean air, given the airborne transmission, using, for example, ventilation and far UV labs. I mean, these are all, some of them require more investment, but I think these are important components for stopping the continuous, the ongoing pandemic. And we don't know what future surprises COVID will hold us, but it's not looking good because there's continual damage to the human bodies getting continually reinfected. Thanks.
Okay. Yeah, I mentioned earlier that reinfections tend to be less severe than primary infections. Primary infections, of course, were generated hospitalizations, and it's varied across countries depending on the resources that the country has and the type of population in the country, if the country has a higher fraction of elderly. So most of the deaths that we have seen, even in Qatar, they are associated with two things. First, of course, the bigger the wave, the higher the number, the absolute number of individuals who is going to get affected. Now people are suggesting that GN1 is the second worst after Omicron. It is generating a lot of infections. So whenever you have more infections, you are more likely to have more hospitalizations. But really the severity that we are seeing is more affecting a specific proportion of the population, those who have a lot of comorbidities and those who are older. These are the ones who are more clinically vulnerable to developing severe COVID-19. Actually, we did a study examining this mortality, and it appears that there is like an accelerated onset of death for these people. And this also has been shown in other countries, like people with comorbidities tend to die earlier if they get hit by the infection. Now, with regards to long COVID, we did not really study this in Qatar because we did not really structure the databases to be able to properly map long COVID. But I just completed a study that examined the risk of stroke following vaccination, and there was evidence that actually there could be a risk for a very specific type of stroke, which is the cerebral venous sinus, CVFT stroke or something. So yeah, I mean, long COVID, we are still to unveil the repercussions of COVID on the long term. And this will require a lot of research to try to really disentangle what could have been really due to COVID or due to other underlying disease factors. And it's not very straightforward. But I do agree with you that there could be multiple factors that play a role in the individual susceptibilities towards specific infections, and which can lead specific individuals to developing more severe diseases than others.
Thanks for that. The single point I wanted to throw in is this issue that COVID seems to have transformed from only causing or clearly causing the acute burden, and we see the hospitalization and deaths, and in some ways, and there's some survivorship bias and perhaps also some decreases of them with the variants, but it's causing a lot of chronic diseases and chronic sequelae. So. It's going to be a challenge. There was the U.S. Senate testimony recently by Ziad Al-Ali and some others, actually, a week or two ago, which was also interesting to tune in. Thank you very much. That was very nice to hear.
Can I ask a question? Hello?
Yes, please.
You hear me, Dr. Yeah.
Yes, I can hear you.
I just wanted to ask, following up on Mr. Khalifi's point, if there have been any studies done on the relationship between having long COVID and risk of reinfection?
And risk of reinfection?
Yes.
Okay. Unfortunately, we did not study long COVID in Qatar yet, because it was very difficult to map what could be due to long COVID and what could be due to something else. And I'm not actually aware of studies that looked at this particular research question, but it will be interesting to see like what would be the long-term effects of COVID-19 and how does this shape transmission.
Thank you.
Just to add on that topic, we're actually here at AUB conducting a research study on COVID-19 on patients who have neurological symptoms also. So we're hoping to get some interesting results. We're currently recruiting patients regarding this. We have one last question from Munir, I think. Oh.
Okay, yeah. I'd like to hear your opinion. Is it the COVID, the Omicron has a higher degree of mutation than the other strain, the original one? Do you have any idea about it?
Well, I think we've observed many more Omicron and sub-Omicron variants than the previous ones. So we've had the BA1, the BA2, the BA4, the BA5, the BA2.86, the BA2.875. So and now the GN1. So I believe yes, and all of them are seem to be like phylogenetically related.
Do you have any idea why is this happening?
Unfortunately, I don't know. It could be. Okay. So there was. It could be due to individual differences in clearing the infection. So early on, we did a study where we noticed actually that some people clear the infection faster than others. So in some people, the infection actually persists for up to 60 days, which is a very long period of time. So whenever an infection persists within a host, it seems that this like I don't know, generates some kind of an interaction that leads to mutation. I'm not a basic scientist, so I don't really know how this happens. But this is like one of the hypotheses that it could be that differences in people clearing the infection could lead actually to generating these different mutations.
Yeah, well, the idea, basically the idea, if you have a lot of people are immunocompromised and get infected, and the virus has freedom because the immune system is quite weak, has a freedom to generate more and more of mutation because it's not much control. This is one of the theories.
Yeah, this is one of the hypotheses.
Okay,
And there could be other factors, but I really did not follow that literature very closely.
I'm sure. Thank you. It's an interesting work. Thank you.
Thank you.
Dr. Milham, one last question.
But just clarification, I want to add to what Dr. Chemaitelly mentioned, that there are other factors that would contribute actually to the evolution of viruses, SARS-CoV-2 and others. And not only the immune, I mean, there is selective pressure from both ends, the host and the pathogen. And Mr. Khalifi mentioned climate change, and now there is a lot of talk to investigate that component, in addition, of course, to the intricate components of the immune system itself and the ability of each one of us, depending on age and the quality of our immune cells, what type of immune responses, let it be anti-inflammatory or pro-inflammatory. So I totally agree with Hiam that this is, you know, a lot of components that require really a long time to study.
And I think Dr. Nada is much better versed at answering this question than me, being an immunologist.
Just for the fun of it, why we a polio virus, which is we have it for 50 years, it still have the same type of virus. It doesn't, we don't have too many variants of it. I mean, those are the question, which means this is inherent to this type of viruses, which they have higher degree of mutation, variability on their surface. It's one way of evading the immune system is by changing all the time. The same with hepatitis C virus or HIV or whatever. But the hepatitis C, for example, is to the extreme. And HIV is also another way of keep changing. So that's the idea. And I have to say, is we recently published a paper in PNAS. We made a vaccine for hepatitis C, a potential vaccine, which is highly variable, and we had some insight into it. Okay. Thank you.
Okay, so with that, we come to an end of this very interesting seminar. Thank you, Dr. Hiam, for this very interesting talk. Any last words before we conclude?
Thank you very much for hosting me. It was very enjoyable to actually give the presentation here.
We were happy to have you also. So thank you all, and
Thank you for attending.
see you on our next seminar. Bye-bye.